Well, hello and welcome to Lecture 18. This is Ward Stevens, and the topic for this lecture is World Health Systems. There are 4 learning objectives associated with this lecture, and you should be able to answer any question on these based on the information within this lecture. So what models are out there? There are essentially 4, and we're going to talk about them and the characteristics of each of those models. And the first model we're going to talk about is the Bismarck model, which was started in Germany. The beverage model, which came out of the United Kingdom or Britain. And then the national health insurance model, which is kind of a combination of the Bismarck and the beverage, and then the out-of-pocket model. So we're going to start with the Bismarck model because it really was the first type of health system that was developed. Is basically insurance model, but it was started by a gentleman by the name of Otto von Bismarck, who was the Chancellor of Germany. He was born in 1815 and passed away in 1898. Otto was a member of what was known as the Junker Party. I hope I pronounced that correctly, but probably not. But they were kind of the conservative elites, you might say, and they were concerned about the possibility of socialists wanting to take over their country. And back then, often that was done at the end of a gun and didn't usually work out well for those who were in power. So he decided to offer health insurance to the population, and this was the first government, at least in the Western world, to ever do such a thing. But today, the Bismarck model has several key characteristics. One is that those who are paying the bill and the providers are private, so not necessarily government run. And the financing of it isn't all coming from the government. It is financed by employers and also financed by employees through payroll deductions. Very similar to private insurance here in the United States. But something that is interesting or makes it different is that insurers cannot make a profit from healthcare services. So you say, well, if I can't make a profit from healthcare services, how do the insurers make money? Well, the insurers can make money through a couple of ways. One is attracting people into their plans by providing good service, and then providing services that may not be available through the regular plan. So perhaps a bad example, but if somebody wanted to have coverage for eyeglasses or to be able to actually have a private room when they're in the hospital, they can pay additional premium to the insurer, and that's where the insurer makes their profits. But there's also a very tight regulation of fees. The health plans, which could be by industry or guilds or other types of organizations, have a lot of power to determine what is going to be paid. And so it gives them a kind of an advantage on the cost side, which if you lower your cost helps increase your value. And then a final kind of characteristic is the insurance companies must accept everybody who applies. And for those who don't have insurance, the government provides a program so that everybody has coverage. And some examples of countries that utilize the Bismarck model, of course, are Germany, Switzerland, and Japan. But here in the United States, the Bismarck model, to a large degree, is very similar to private insurance here in the United States. Now, the second model we're going to talk about is the Beveridge model. It was named after a British economist, William Beveridge, and he was a key architect of the British welfare state. And kind of the background with that was a lot of this occurred after the Second World War. And if you've read World War II or seen newsreels about World War II, Britain was to a large degree devastated, particularly in areas such in the big cities such as London. And following World War II, they basically had no healthcare system. Most of it was whatever they had before was destroyed. And so under this model, it's different than the Bismarck model in that the healthcare providers are either employed or contracted with the government to provide care. The government also runs the hospitals, and it's kind of a little bit of a different mindset than we have here in most of the in the United States and perhaps in Germany and other countries, in that healthcare is viewed as a public service. Healthcare is provided just like police protection is provided, or fire, or those types of services, roads, and so on. So it's just something that the population there expects the government to provide. It is financed largely through taxes, and there are no bills for services provided through the government system. Now, that's what one of my sources say, though I do believe that patients might have to pay small co-payments for certain services at certain points in time. But largely, you receive your care. You're not going to receive a huge bill that somebody is going to have to administer and get paid. And some of the countries that use that, of course, are Great Britain, Spain, Italy, and most of the Scandinavian countries such as Norway and Denmark and Sweden, Finland. And then we have the national health insurance model, which is essentially a hybrid of the Bismarck and Beveridge model. So the providers are typically private, like the Bismarck model. The payer is, I'm going to say, primarily the government, like the Beveridge model. All citizens have to pay into the system. In the United Kingdom, that's done primarily through taxes. In the Bismarck model, it's just like we do here in the private insurance here in the United States. But because the government is the payer, they have almost absolute power to negotiate the prices that are paid to the providers. And examples of countries that utilize the national health insurance model are Canada, Taiwan, and South Korea. And then we probably have the oldest model of all, the out-of-pocket model. And we know how that works. Care is paid for by the patients. If you have no money, you have no care. And it's actually the way it is in about 160 of the world's 200 nations, and for the uninsured in the United States, and frankly anywhere else. And the truth of the matter is that many people who pay out of pocket simply don't seek healthcare services. It was an observation. A couple of years ago, I had the opportunity to go on a mission trip with VCOM down to Honduras. And the way it worked down there is for patients who wanted to have surgery, is that they pretty much paying for a lot of it out of pocket. And if they were having surgery, they would go to the pharmacy and buy the supplies. And when they were able to buy all the supplies, they could go to the hospital, and the hospital would provide the surgery. And so it's kind of hard. Pretty much limits one's ability to make good healthcare decisions to be able to get the care that you would need. So one of the things I just like to touch on is just kind of out-of-pocket spending as a percent of health expenditures. And this is for 2020 or the closest year. And you can see that it varies. And according to this graph, about which I got from the OECD.org, and you can go there and check it out. If you want to, you can update the numbers for me and let me know if they've changed very much. But about 11.3% of healthcare spending in the United States was out of pocket, whereas in Switzerland, which was the highest, it was about 25.3%. And you can see that, I think with the exceptions of the Netherlands and France, all other countries have about the same or higher out-of-pocket spending than we do here in the United States. Now, when people throw numbers like this, like I just did, you also have to remember what the base, what's really important here. And it's, I think, just important to note that, we pay 11.3%, which seems very reasonable, but it's 11.3% of $13,000 per year and not 13.7% or 9% of, we'll say, $9,000 per year. So it's you can't always just look at the percentages. So what are the shared characteristics? I kind of noted them as we were kind of going through. But with each of these systems, with the Bismarck model, the Beveridge model, and the National Health Insurance model, these three things occur. Everyone is mandated to have healthcare insurance. In the United States, with the Patient Protection and Affordable Care Act, we had the individual mandate. We'll talk about that more later. And then in all these countries, the government, really the taxpayer, remember it's individuals who ultimately pay for everything, pays for or subsidizes care for the poor. And then the third big one is that the physicians and hospitals accept negotiated or mandated fees. And if you think about being able to make providers accept negotiated or mandated fees, it can really help you provide value, because it's really hard for physicians to move countries to go get paid better. You kind of have to take what you want. So there's a lot of ability to control the denominator of the value equation. And as I think I noted, at least partly, is that there's examples of each of these here in the United States. The Bismarck model, U.S. privately insured individuals such as myself. You have the Veterans Administration system, where the government is the payer, beneficiaries, veterans who go there have very low cost for a lot of the services that they receive, but the facilities and the doctors are typically all employed by the VA. And then we also have the National Health Insurance model with Medicare, where the federal government is the payer for all Medicare patients, and pretty much every single provider that provides the services is private. And then we also have out of pocket, and out of pocket is out of pocket. So which system is best? If we take a look at the Commonwealth Fund rankings, which we've seen before, just kind of ranked them in alphabetical order, I believe, right there in the ranking, and then noted the type of system that they utilize. And when we look at it, of the top 11 countries that were mentioned, the 6 countries that, if we kind of just look at the average score, their average ranking actually, is that the Beveridge model had the most countries, the Bismarck model had the next most, the National the second, and then the United States, which is the combined model, averaged the worst. Now, just need to note that part of this could be the countries that were selected by the Commonwealth Fund in their comparison. And we could probably find other countries out of the 30 or so, that the many that they look at, and make the United States look better if we wanted to. So there may be a little bit of bias in it, but compared to the countries in the Commonwealth Fund report, the combined model doesn't work the best, and the Beveridge model works better. But I think the takeaway from that is that a lot of times we talk, oh, we want Medicare for all, which is kind of the National Health Insurance model, or people want a model like the Beveridge model. But I think we can recognize that there are a lot of different models out there that have lower cost and provide, depending on how you want to measure it, provide a good value of care to the citizens of their country. So having a 100% government-run system like the UK is certainly one option, but there are others out there as well. So this presentation has been pretty short, only about 15 minutes. I know you like that, but there's something that I'd like you to do and consider it as part of this presentation is to take some time and watch Sick Around the World. It's a PBS commentary back from 2008, which I recognize is a little bit old, but I think it does an excellent job in showing what other countries do to provide care to their citizens. And none of these countries, in my opinion, have the perfect system in and of itself. But if we're going to address issues within our country, it might be a good idea to see how they do that. So please take time to take a look at Sick Around the World. If you have problems with that link, it worked for me a few minutes ago, but if you have any problems, please just get in contact with me or go on to YouTube and see if you can find it. You should be able to just put in Sick Around the World and be okay. So thank you for listening, and let me know if you have any questions.